Occupational English Test, Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1. This is an edubenchmark.com sample test paper. Extract 1. Questions 1 to 12. You hear a doctor in the hospital talking to a patient presenting with jaundice. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Stevens. So I see here you were referred to the hospital by your GP.
Yes, but you can call me Marie.
Okay, so Marie, what was the initial reason you visited your GP?
Well, I went to my GP last week because over the last 2 weeks, I'm getting more and more yellow. It's my skin and my eyes, basically. I didn't think it was all that bad, but my husband said I was very yellow, especially the whites of my eyes.
And any other symptoms?
Yes, I'm also getting a lot of tummy pain, and it's been getting much worse.
So you said your husband first noticed the change in your skin. When was that exactly?
I think it was about 12 days ago when he said he first noticed something was wrong.
And you also mentioned experiencing tummy pain that is getting worse. Is the pain constant or does it come and go?
It is intermittent pain, but I think it might be related to my bowels in general. They have been a bit off lately.
What would you say has changed with your bowels?
I guess a change in bowel movements. They've been a weird colour recently, a bit pale, I guess you'd say.
And what about urinary output? Is that normal?
Output is normal, but my urine is definitely a lot darker than normal.
And going back to the tummy pain, where would you say the site of the pain is specifically?
It's here on my side.
Okay, so you're indicating your right hypochondrium. And how long has it been going on?
It's been on and off for a few months now.
And what kind of pain is it? I mean, is it a sharp or a dull ache?
Well, it can be quite sharp, and when it's bad, it can just completely stop me in my tracks. I mean, it can be so bad that I often feel nauseated when it's happening. I mean, it was easy enough to ignore it at first because I'd get the pain every week or so, but now I'm getting it at least 1 or 2 bouts a day.
So, a dramatic uptick in frequency. Does anything seem to trigger the pain or make it better?
I started noticing that if I eat a big dinner, it'll get more painful. I don't eat much at all now because it makes me sore and a bit nauseous.
Okay, so now I'm going to ask you a few questions about your past medical and surgical history.
Oh, well, that's quite brief. The only times I was ever in the hospital before today were for the birth of my 2 children and for appendix surgery when I was a teenager.
And have you ever had a blood transfusion?
Not to my knowledge.
What about drug history? Are you currently taking any regular medications?
I just take a blood pressure tablet. Can't remember the name, but I've taken it for years. Other than that, I don't take anything.
So, you're not at risk for drug-induced jaundice. As for my physical examination, on palpation there are no masses, but there is tenderness in the right upper quadrant. So I'm going to order some investigations. We need to get a full blood count, a liver function test, as well as serum lipase and amylase, so that we can rule out pancreatitis. I'm also going to order a coagulation screen to assess the liver's synthetic function. Imaging tests will also be needed, but I will wait for the results of the other investigations before deciding which of these.
That sounds like an awful lot of tests. I mean, what do you think?
This is an edubenchmark.com sample test paper. Extract 2, questions 13 to 24. You hear a doctor in the A&E talking to a man with blood in his urine. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Andrew, Yates, is that correct?
Yes, Doc, that is my name.
So, Mr. Yates, how old are you?
Just turned 55 last week.
Well, happy belated birthday. So, according to what I have here, you have visible hematuria, blood in your urine.
Yes, that's right.
So, when did you first notice blood in your urine?
My urine has probably been pinkish for the past week, but it got worse recently.
How so?
Well, it's gotten darker now, a dark red, in fact. It happened over the last 24 hours or so. It's quite alarming, really.
Have you had trouble passing urine?
Well, it's becoming difficult. I mean, I feel like I have to force the urine out, and my tummy is becoming quite uncomfortable. I went for a wee last night, but couldn't this morning.
And have there been blood clots in your urine?
Oh, yeah, I've been passing quite a few.
And when you did manage to pass urine, did you feel burning or stinging? Anything like that?
No, it was just difficult to get it out.
Okay. And other than your tummy feeling generally uncomfortable, do you feel pain elsewhere, like your back?
No, nothing like that.
And prior to this, did you suffer any nocturia?
Do you mean having to go in the middle of the night? In that case, no. You're thinking prostate cancer, aren't you, Doc?
Well, that is certainly a possibility.
Well, no family history of that or anything like that.
So, no family history of bladder or renal cancer either?
Not that I'm aware of.
So, now I would actually like to focus on your past medical and surgical history. Do you have any other medical conditions?
Well, I have high blood pressure, like most people my age, but other than that, no medical problems. I mean, my problem is well controlled with medication.
So, no history of urinary tract stones?
Absolutely not.
What about your use of tobacco and alcohol? Have you ever smoked?
Well, I've been a smoker since I was 20, and usually smoke around 20 cigarettes a day.
Mr. Yates, we are going to do some investigations, but I do need to tell you that bladder cancer has a strong association with smoking. The most common type in the UK is transitional cell carcinoma, which has a 5-year survival rate of 90%. But let's not get ahead of ourselves.
What can be done for bladder cancer? I mean, do you remove it?
Let's not go down that road yet. This is what we will do first. We need to insert a 3-way catheter to do a bladder washout and start ongoing bladder irrigation. But as I said, first we will need to do some investigations, including urine collection for culture to rule out an infective cause of the hematuria, as well as blood tests. This will hopefully help to settle the hematuria. Also, we'll need to check your hemoglobin level, as if it is too low, you may require transfusion. Finally, a bladder scan is needed to assess evidence of clot retention.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear part of a conversation between a junior and senior doctor. Now read the question. This is an edubenchmark.com sample test paper.
Dr. Adams, I have a patient I would like to get your advice on.
Of course. Is this the patient that just left?
Yes, she is complaining of chronic recurrent headaches that have been going on for about 4 months. So we went through the symptoms related to the headaches as well as what works and possible triggers.
And I'm sure you covered preventative measures related to lifestyle choices.
Yes. My question now is when I should consider preventative treatment.
Well, the severity of the headaches is a key criterion, including the frequency and impact to everyday life. It is also necessary to ensure that triptans and other painkillers are ineffective before looking at prophylactic management options, which include
Question 26. You hear part of a training on the classifications of strokes. Now read the question.
So today we are going to review the major categories of strokes, which are ischemic and hemorrhagic. There are several mechanisms related to the first classification, such as embolism, thrombosis, systemic hypoperfusion, and cerebral venous sinus thrombosis. All of these mechanisms reduce the blood supply to an area of the brain. With the other category of strokes, there is a rupture in blood supply, such as with an intracerebral hemorrhage and subarachnoid hemorrhage. So, what I want to get into today is the Bamford classification of the first category of stroke. The basis of this system is initial presenting symptoms and clinical signs. It does not rely on imaging and is instead a purely clinical diagnosis. So the first category in this system is a total anterior circulation stroke, which has 3 criteria for diagnosis. The first is
Question 27. You hear part of a ward briefing about documentation of results. Now read the question.
So we've been having some issues with thorough documentation of chest x-rays lately. So I just wanted to briefly cover the essential elements for documenting the results of this test. So first, it is necessary to write the date and indication for the chest x-ray, such as patient presented with shortness of breath. Then the next important component is the interpretation, which includes a number of important areas to cover, such as image quality, airway, breathing, cardiac, diaphragm, and other. Under airway, it is necessary to refer to the trachea, carina, and bronchi, as well as the hilar structures. For breathing, information related to lung fields and pleura is essential. In the case that no abnormalities are observed, that should be noted as well. There is no time for me to go into the specifics for the other 3 areas at this time, but I'm leaving information as well as an example of documentation for everyone to review. The final 2 parts are your overall impression of the chest x-ray as well as the plan based on the findings. The plan should be as detailed as possible, including further investigations and therapies. Many people have left out important details of this part, such as how long a therapy should last, so please double-check this part. Being as specific as possible helps to save time for the whole team, so
Question 28. You hear part of a ward briefing on history taking and information giving. Now read the question.
In light of several instances of missed opportunities when it comes to history taking and information giving, I wanted to focus on patient communication. So the framework that you should keep in mind can be easily remembered by the initials ICE, ICE. I stands for ideas, C for concerns, and E for expectations. Asking a patient about these areas enables you to gain insight into how the patient currently perceives their situation, what they are worried about, and what they expect from the interaction. Some questions that you can use to get at the patient's ideas include, tell me what you think is causing the problem, or do you have any ideas as to what is going on at the moment? These types of questions might lead to the patient talking about triggers or related symptoms that have not come up before. When it comes to concerns, questions related to a patient's biggest worry can help to direct treatment so that it is in line with patients' wants and worries. So, the final area of questions includes asking about expectations related to current problems, such as what you were hoping would happen today. Similar to concerns, this helps you to get a good idea of the mood of the patient as it relates to
Question 29. You hear a dermatologist reporting results to a GP. Now read the question.
So, as you noted in the patient's file, the lesion is pigmented. Based on that, I looked at asymmetry and border irregularity, which both showed indications of sinister pathology. The colour variation within the lesion was also concerning, as it showed more than 2 colours. The diameter of the lesion is still under 6 millimetres, but the lesion is bigger than when you saw the patient.
So, increasing size, that does not bode well.
No, it does not. Neither do the symptoms that the patient described, itching and scabbing of the lesion. So the next step here is to perform a biopsy to determine if the lesion is precancerous or cancerous and help us determine next steps.
I see. I'll be seeing the patient next week, so...
Question 30. You hear 2 nurses discussing hand washing. Now read the question.
Well, I guess the silver lining of all this virus situation is that I have seen a marked improvement in people's hand washing technique.
Yeah, you can say that again. More people are definitely remembering what they taught us in our training about the 5 moments of hand hygiene, particularly after touching a patient and patient surroundings.
Yes, and people are actually taking the recommended amount of time to wash their hands. There is one area I do think people need to be reminded of, and that is the benefits of alcohol-based formulations versus soap and water.
What do you mean by that?
Well, alcohol-based formulations are good for some situations, and it is faster and better tolerated by the skin on your hands. However, they're not appropriate after you've just been to the toilet. In that situation, soap and water is necessary.
I see what you mean.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear part of a training for A&E doctors about a type of suture. You now have 90 seconds to read questions 31 to 36. This is an edubenchmark.com sample test paper.
Welcome, everyone. As you already know from last week's training, my name is Dr. Padu. So, last week we covered the horizontal mattress suture, which, as you may recall, is a useful suture for high-tension wounds, especially when the edges are fragile and frayed. We also looked at the corner stitch, a variation of the horizontal mattress suture, which is commonly used for closure of angled skin flaps and wounds. So, today we're going to do an overview of the vertical mattress suture before going into the skills lab to get some practice with this useful but somewhat underutilized suture. Some of what I'm about to say will be the same or similar to what we saw last week with the horizontal mattress suture, but it is always useful to review this information as well as to make sure you understand the similarities between these suture types. So, the vertical mattress stitch is a suture type used to close skin wounds. This stitch is used most commonly in anatomic locations prone to inversion, such as the posterior aspect of the neck and sites of greater skin laxity. It is also useful for deep lacerations, where it can replace 2 layers of deep and superficial sutures. Vertical mattress sutures are not recommended for sites such as the palm of the hand, where important structures lie fairly superficial to the epidermis. As I've already alluded to, this suture type has a number of advantages, such as providing closure for both deep and superficial layers, and also allowing for perfect eversion and vertical opposition of the superficial skin edges. The disadvantage of this suture type is that it is time-consuming and unforgiving of operator error, meaning that poor vertical alignment of edges can result in cross-hatching or small scars being left along the main wound. The propensity of the vertical mattress suture to create cross-hatching limits its use in cosmetically sensitive areas, such as the face. To minimize the risk of scarring, the recommended time for removal of this suture is 5 to 7 days. If it is deemed necessary to leave the suture in place longer, bolsters may be placed between the suture and the skin to minimize strangulation of the tissues when the wound swells in response to post-operative edema. So, just a few reminders about the basic principles of wound management. First of all, patients should be up to date with their tetanus immunization, and contaminated wounds warrant a course of an antibiotic. Also, X-rays should be performed if there is any suspicion of a fracture or foreign body. Finally, wound edges should be debrided if the wound is contaminated, and only if there is no damage deep to the skin can a primary closure be performed. So, going into the procedure. As with any sterile procedure, once the wound has been treated with a local anesthetic, it, as well as the surrounding skin, must be prepared with an antiseptic solution before placing a drape around the sterile field. In addition, you must wash your hands and wear sterile gloves, taking care not to desterilize during the procedure. At this point in the procedure, you should also plan the entry and exit of your suture on either side of the wound. So, now on to technique. The vertical mattress stitch is placed in a far-far, near-near order of bites. The far-far loop passes relatively deeply into the dermis, approximately 7 mm, and the near-near loop enters and exits the skin surface 1 to 2 mm from the wound margin and traverses the wound at 1 mm depth. It is important to remember that you will reload for the near-near loop with your needle facing away from you, and then throw the suture directly above or superficial to your original throw. Because of the precise degree of control that the vertical mattress stitch provides, bites must be symmetrical, especially in the near-near loop, or the wound will misalign. Now, the knot is tightened only until sufficient opposition and eversion is achieved. Over-enthusiastic tightening increases the likelihood that the suture material will cut into the skin during wound healing. Also, the knot will lie to one side of the wound because you have both suture ends coming from the same side. So, just to review before going into the skills lab, this is a good suture for
Now look at Extract 2. Extract 2, questions 37 to 42. You hear an interview with UU2, a researcher specialising in malaria. You now have 90 seconds to read questions 37 to 42.
So, today in our series on women who shaped medicine, I have the honour to introduce Mrs. Tu, who is the first mainland Chinese scientist to receive a Nobel Prize in a scientific category, and she did so without a doctorate, a medical degree, or training abroad. Simply amazing. So, please receive a warm welcome, Mrs. Tu.
Thank you for having me. It's a pleasure to be here.
So, I just gave a bit of information about your background, but it definitely does not tell the whole story. What inspired you to become a scientist?
Well, education was always important in my family, but the time in my life that had the biggest impact on my future was when I was 16. I contracted tuberculosis and I had to take a 2-year break from studying. When I eventually returned to school, I knew exactly what I wanted to study: medicine. I was driven to find cures for disease like that one that had afflicted me. So I studied pharmacology, including learning how to classify medicinal plants and extract active ingredients and determine their chemical structures. When I graduated from college, I started working at a newly established institute, the Academy of Traditional Chinese Medicine.
Very interesting, that focus on medicinal plants. So when did you set your sights on malaria, research that would eventually lead you to the Nobel Prize?
Well, that was in mid-1967 when North Vietnam asked China for help battling the disease because it was causing tremendous casualties among its soldiers in the war. The parasite that causes malaria had become resistant to chloroquine, the standard malaria treatment at the time. So Chairman Mao Zedong launched a project to find a cure for chloroquine-resistant malaria. A few years later, I was appointed to head the project.
So how do you even go about taking over such a huge project like this?
Well, my first order of business was researching the effects of malaria in situ. At the time I took over the project, Hainan Island in southern China was experiencing a malaria outbreak, so I travelled there to see for myself the effect of the disease.
So you witnessed firsthand the disease's devastating toll on the human body.
Yes, I did. When I eventually returned to China, my team started to review ancient medical texts to understand traditional Chinese ways of fighting malaria. I mean, we had to do something. At that point, over 240,000 compounds had been tested for use in potential anti-malarial drugs, and none had worked. Eventually, we found a reference to sweet wormwood, which had been used in China around 400 AD to treat what was intermittent fevers in the text.
Ah, I see. Intermittent fevers are a symptom of malaria.
Exactly. Once we knew what we were looking for, it didn't take us that long to isolate one active compound in wormwood, that seemed to battle malaria-friendly parasites. We tested the extracts of the compound, but nothing worked. So we went back to the ancient texts.
What were you looking for exactly?
Well, I wondered whether the active ingredient in wormwood was being damaged when we boiled it to preserve the solvent. So I tried another preparation, this time with an ether-based solvent which boils at a lower temperature. This preparation didn't damage the wormwood. Animal testing showed a 100% success rate with this new preparation.
That is amazing. 100% test rate. So how did human testings go? How did human testing go?
Well, actually, 2 colleagues and myself were the first human test subjects, and then we tested it on 21 patients in Hainan province. The good news is all of us recovered.
That is definitely dedication to one's work. So when things calmed down, what was found to be the compound's active ingredient?
The active ingredient is called artemisinin. I think of it as a gift from traditional Chinese medicine to the world.
It truly is. And how did you feel about the amount of time it took for the World Health Organization to recommend artemisinin combination therapy as a first line of defense against malaria?
Well, it did take us a few years to get our work published in English, so there is that. I mean, the WHO, World Bank, and UN became interested in our findings soon after that. So I guess what I'm trying to say is the important thing is that patients started to receive effective treatment.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.